Good morning to all of you, and I welcome all of you on behalf of the Perinatal Society of Sri Lanka. Today is one of the events marking series of events we have organized for the annual scientific congress, and yesterday we had the webinar as well as we had the regional visit to look at how the maternal health care is provided. So today's workshop will be on how we apply 10 group classification system and how we look at our data, especially the Caesar rate. And without taking much time, I'd like to invite President of the Perinatal Society of Sri Lanka, Dr. Susi Perera, who is the Deputy Director General of Health Services, Public Health Midwife, and Public Health Services. Thank you very much.
A very good morning to all of you. It's good to see this important gathering here today. And we are here to listen to Dr. Michael Robson, who has come all the way from Ireland. He's a WHO resource internationally for his framework that he has put in identifying a 10-group classification which will improve delivery outcomes. So the Perinatal Society of Sri Lanka took this very important decision that because as a society we are a group of professionals who work together, obstetricians and gynecologists, pediatricians, neonatologists, consultant community physicians. So we have a very strong collective bond, I would say. And this is a good time to support the national program. So Dr. Chitramali De Silva is here. She's the Director of Family Health Bureau. You all know her. And the national program, the team is here. And I also recognize so many of you, the obstetricians and gynecologists, pediatricians, as well as maternal and medical officers of maternal and child health, and several of you who are going to be the future cream of the professionals in the country on this subject. So today we are going to listen to the person who actually contributed this thinking, a framework of thinking, understanding the data on ground. So I think this is a new way of thinking, and let's listen to him. Please make the most of this day, and you are free. I'm sure he's going to be a very engaging lecturer. I don't like to use the word lecturer, but it should be a very engaging session today, this morning, and it's all up to you to make the most of it. So we are thankful that the Sri Lanka College of Obstetricians and Gynecologists have brought together their professionals in good strength to participate here, as there is much to take forward with the national program. So thank you. And I invite Dr. Michael Robson to talk to us, to engage us, and we look forward to hearing you.
So, good morning. First of all, it's really important for me to say how grateful I am, and more importantly, how privileged I am to be invited here today and for the next couple of days to share in discussion, talking about lecturing. I would see it more as a discussion and interaction of ideas. I think that you've seen the program. It's about 3.5 hours, maybe a little bit more. The time of a pretty good marathon. I don't know whether any of you run marathons. I don't myself. But in a marathon, there's going to be ups and there's going to be downs, and it's hard to concentrate for 3.5 hours. So don't worry about that. I do believe this is going to be recorded, and I'm very happy for it to be used in any way that you feel deem suitable. So you can listen to little bits again, because there's a lot to talk about, and there's a lot to think about. And as just in my introduction, this is a framework. It's not a session about how to do or how to look after women in labour and delivery, but that's where we're coming from. But it's more a structure within which to look at things. You've got the program. The timetable is going to be roughly that. There's going to be plenty of times for questions. By all means, if you want to interrupt and ask a question of fact, please do so. But there will be times where we will have questions, good times. There'll be a break halfway through. And there'll be good opportunity to take any points further in that. But the timetable may not run exactly according to that, but we'll give in some structure to it. That's fine. I should start really by introducing myself. Michael Robson is my name. I grew up in Norway. I'm English. I work in Dublin, Ireland, and I've had the opportunity, and again privilege, to travel lots of places and to see different things. And I think that shapes a lot of the way that I think about things. I'm a full-time clinician. I'm neither an academic nor a scientist. This is almost my hobby, or it's become my hobby. And like everything in life, when it's a hobby, you put a lot of enthusiasm and effort into it. And I think that will come over in the discussion. So let's start then. Just a little bit of background. I find with something like this. Oh yes, that would be great. Thank you. Yeah, something like. Can you hear me? Yes. Something like this. It's always worth knowing how it all started. And when I was a registrar, I had the opportunity to move from England, for different reasons, to Ireland to get a job in the National Maternity Hospital. Some of you may have heard of the National Maternity Hospital. You might have heard of a concept called active management of labour and O'Driscoll. And at that time, there was a big debate between the UK, between Dublin, Ireland, mainly the National Maternity Hospital, and some clinicians in the States about the best way of managing labour in first-time mothers at 37 weeks or greater in spontaneous labour. And I came into that debate not having done very much obstetrics, but I was quite taken by the debate and the discussion and the no agreement of how was the best way. There was randomized control trial, there was observational data, and there was just didactic ways of doing things. But that's how it all started. And it was this group of women, I think the biggest challenge to us in labour and delivery, and the biggest difference between different countries and different hospitals, that proved the seed of the 10 groups. And we'll go into more detail, but that obviously became group 1. And the other 9 groups developed of that for different reasons. And I'll explain to you why and how that came about. But we've got to put all of this into context. Whatever a debate about a cesarean section rate, which was as lively then as it is now, although at lower rates, we've got to make things quite clear. Women healthcare professionals and governments are interested in safety and quality, more so now than ever before. Those are the two issues, and safety above even quality. Quality is a more subjective issue. And I believe that simplicity and consistency are the best way to achieve this. It's got to be simple, and it's got to be able to be consistent in daily practice. And as clinicians, I would hasten to say that we all, in most given clinical situations, know what's right and what is wrong. And often our problem is actually proving it. So much so that my definition of evidence-based medicine is personal opinion based on fact. Now, that's not an issue, that's not a problem, but it's important to have insight on it. We have very definite views, and the more experienced you are, the more definite those views are. And if we read a paper, I don't know whether any of you have read a paper, a clinical paper, where the title concludes something which you obviously disagree with very vehemently, and then read the paper. Have you ever changed your mind as a result of it? If we're honest, it's not very often that happens. What happens is that you challenge in your own mind the paper, and you say, well, I'll go and find some evidence somewhere that supports my way of doing things. And if you can't find it, then you criticize the paper to say why it was done wrongly and shown something wrong. And that's really being honest. And I think today there are competing philosophies in evidence-based medicine. There's the process-driven philosophy, where you take different processes, you choose them, you analyze them in what we call randomized controlled trials, and you decide which is the best one. Having decided which is the best one, you carry out care in that way. To strengthen that, you often take different randomized controlled trials on the same process or close to the same process, and you put them together in meta-analysis, and that strengthens that opinion. And that's all very well. The opposing, if you like, or the competing philosophy on the other side is what for this lecture I'm calling perinatal audit. It is actually an epidemiological study. It's analyzing what you do, and depending on the results, you go back and change any processes that you carry out according to that. And it's very important when you think of those things, and I know randomized controlled trials are the vogue at the moment in evidence-based medicine, but we have to challenge everything. But they depend on relative outcomes over a limited period of time in one setting, while perinatal audit concentrates on absolute outcomes over an indefinite period of time in any setting. And it's really important to understand that. And as RCTs continue to ascend in the evolution of evidence-based medicine, some people are educated in the sense that if it isn't a randomized controlled trial, throw it out. A lot of editors of well-known journals feel that way. We must recognize and respect and acknowledge the limitations when examining complex phenomena in heterogeneous populations. And there's nothing more complex or heterogeneous than in childbirth, and especially labor and delivery. If you look at other organizations, business, professional sport, who also look for quality, safety in a different way, but safety of business, I don't see them doing randomized controlled trials. What I do see them do is routine data collection, different ways of analyzing it, and changing things. I don't know how many of you watched Arsenal Manchester United last night. I'm an Arsenal supporter, and Arsenal won. The amount of information Premier League clubs know about players, what they do in the game, how many times they touch the ball, in which parts, I can go on and on. My niece works in an information organization that looks at professional sport. But that's how they invest money to buy certain players. And it's not just about how far they run, it's where they run on the pitch. My point being, we can learn from other organizations that there are other ways of looking at things. And I would argue safety and quality are ultimately related to outcome, and it is outcome that guides processes. Or to a more rational person, it's a bit of both and not just testing processes. So where I was at that time, and just being in the right place at the right time, this big debate, I was trying to work out there must be a better way of understanding things, and certainly for childbirth and labor and delivery, and that's where this all started. And it started with certain statements that the first measure of safety, quality, and consistency in any organization is just knowing what your results are. And I think that's what should be rewarded by governments and formal institutions, just knowing your data or being able to collect the data. And then the second measure of safety, quality, and consistency is this ability to understand the results, compare them with other delivery units, and use them to improve quality of care. And dare I say, learn from other people trying to do the same thing as you. And that is what I'm going to refer to as classification in this lecture. So perinatal audit, what is it in everyday practice, is continuously looking at your outcomes in a standardized way at the most senior level, and that means them knowing the results, but also publishing a formal written annual report documenting the quantity and quality of care. It's not until you document these things and have them as a publication within your own organization, indeed within your own country, that it really nails the point and forces you to think exactly what you're writing. Essentially, a continuous epidemiological study. But why is it so difficult? It seems very simple. Why are we behind, in medicine compared to businesses and otherwise? Well, it's not recognized at the moment as an entity, a specialist area, or even at all useful. And as I've said, it's a poor relation, in my view, of RCTs, which essentially compares processes only. Collection of routine quality data is resource dependent, and it requires total organizational committee. In some places, they have one person, that is in charge of the collection of data. Everybody has to contribute to it for all kinds of reasons, which maybe will come up in discussions. But at the moment, there are no accepted classifications. That's changing, maybe. There are certainly no principles, and most importantly, there's no training programs. And few delivery units, regions, countries have committed to routine quality data collection and organization, classification of the information. And this is really putting this into context. This is nothing more than an audit cycle, which you're all aware of. But I want to try and put it into context in the sense, and I don't know whether you can all see that from the back, but there are different parts to this cycle. There's the actual collection of the data before labor, during labor and delivery, and after labor. The collection of the information, when, who, how, and why. It's all very well collecting information, but we've got to be aware that, if you start collecting everything, you won't be able to collect or certainly remember the important thing. So that's one aspect of what you've got to think of if you're serious about this. How do you collect it? Who is it collected? And then there is the organization of the information. That's the classification. That's where I've become interested, obviously, with the 10 groups, and its purpose, and you've got to define that. Now, they are two important components, and none of these components work unless you've got all of them. And that's the important thing that people don't realize. And you've got to identify whether it's one place, two parts of the cycle, or all of it. And that's even before the very difficult part is, even if you did have all the information, even if it was organized, how do you then assess management? How do you interpret it? How do you modify it within your organization? And how do you encourage, inspire with enthusiasm to keep on continuing to collect it? Because when I talk about an audit, I mean continuous audit, a bit like a business. I don't mean a one-off thing for 3 months and you leave it. So at different times, you may have to add more information as practice changes, and you may have to say, well, that information, we just haven't got the resource to collect. And that will vary in different parts of the world, and to do with your local outcomes, events, or indeed your local resources. And the quality assurance program, the cycle which I'm talking about, it depends really on professionals' understanding and knowledge of the information, the ability to quickly respond and change as a result of information, and the ability to perform and continuously reassess information. So it is a culture And Professor Pereira was talking about, a new way of thinking. It's a total new way of thinking. Or like a lot of things, it's an old way of thinking, but it's reborn, and it's a very simple way of rethinking. So that's the first part. There's 2 other parts to this first session, and then we can maybe bring up any questions. I want to talk about routing data. What do we actually mean? And I think, like a lot of these slides, there's some key slides that are quite important. The information may be prospective or retrospective, and it may be either perinatal or non-perinatal. And it's really important to understand what I mean by that. So what I mean by prospective information, that is information you know before delivery, if you like, before even some of it, before pregnancy. And that information may be perinatal, relating to pregnancy, or maybe non-perinatal. So parity, previous obstetric history, category of pregnancy, which I'll explain what I mean shortly, the pathway to delivery, and gestation. These are the fundamental principles that make up the 10 groups. And they're very important to understand, because if you can put a classification of that, you can identify different groups before the retrospective information, which is below, comes into play. The non-perinatal is age, BMI. They're the most important ones, but also case mix and other medical conditions, which a lot of people, and for example, tertiary referral units will always say that's why we've got a high intervention rate, and often that is true. But often it isn't actually proven to be true, and more interest should take part. But age and BMI in particular, so they're all prospective. So you can devise a structure based on that, and then look at the retrospective information, which is information after the event, after delivery. They're all the labor events. Within labor, rupture membranes, oxytocin, epidurals, fetal distress, suspected fetal distress, all the types of deliveries, the interventions, inductions, cesarean section, complication, adverse events. So they're all the ones that mostly we're interested in observational databases. But if you just list them at the end of delivery, they may be very interesting, but what I'm trying to say is you can't go back and identify prospectively which groups there may be a different incidence in, because you don't want to change management or change care in all of them. You want to specifically tailor your changes or continue to manage in the same way. So they're related to pregnancy. Now, all of these need definitions, and some of them are easier to define than others. So how do we succeed with routine data collection? And the challenge is we want to combine routine notes, looking after the patient, recorded in such a way and structured in such a way that we can audit and look at our results. But we also want to use them for teaching or education and research. Now, this has, held observational data collection or routine data collection back, because with a randomized controlled trial, you get a whole lot of money and you collect very good information for a limited period of time. But to do it on a regular basis really needs very careful thinking. And the other thing is that you can do so much with pencil and paper and recording it, but then it stops, certainly when you're dealing with large numbers. And that's where electronic record or electronic charts actually come in. But this is, if you like, our history or my history of starting off with a very simple partogram here in labor and delivery, a more sophisticated partogram including antenatal and postnatal events, carbon copies, so one can go into the chart and one be kept in these folders, and then drifting on to the electronic chart, and this is an old version of the concept, but similar in many ways to the audit software program that I've spoken to you some about. And as far now to an electronic database, the intrapartum audit program, which I've talked about, But now to the position where one of my responsibilities, apart from my clinical job, is as clinical director of the development of the maternal and newborn clinical management system, which is essentially an electronic record, and hopefully the same one with a lot of detail. It is the electronic chart, all the detail about what happens in every single hospital in Ireland. We've got 19 hospitals in Ireland. We've implemented it in 4, and we're hoping to implement it in the others. But any of you involved with implementing any part of routine data collection, but particularly an electronic record, will know that there are frustrations, let's say, with doing that. And sometimes a long-term strategy has to be developed, but a short-term strategy as well in many situations. And certainly that is part of the discussion which I think we need to have. Okay, and I'm just going to finish off with the next session, which is the principles of classification in general terms. What is the purpose, the importance, the benefits and challenges of classification? Well, what you have is raw data, primary data, just like primary numbers, primary data, which can't be divided anything up into any more detailed information. We need to convert that raw information into useful knowledge, which will help us to learn from each other and improve care. We have this situation in our practice where this event, the amazing event of childbirth, occurs and is going to occur on a regular basis in every country in the world. And we have all the information that is being collected in greater or lesser ways, but doing things in different ways. If we could standardize the way that we classify, we surely should be able to learn a lot from each other. And that will bring on a lot of other advantages as well. So it's trying to achieve complexity, which is useful knowledge, but through simplicity, an intelligent organization of raw data. And it's not necessarily a lot of data, but it's very specific data, and it's the relationship of that data within different groups, classified groups. And the 10 groups is a language, really, the way that I look at it, that brings all those caring for the pregnant woman and a baby together to share experience, to learn from each other, and improve the care given to all women giving birth. It's a common language. It is a starting point. And like all language, it will depend on how it's used. And when you go to different countries, it's always been strange to me to realize that there are some words in one language you can't translate into another. You just can't do that. I grew up in Norway, and I'm English, and I know there are certain words that don't describe what I mean in English when they're used in Norwegian, and I'm sure you find the same thing. But if the language is very simple, discipline and enthusiasm will result in great insight and reward. And most importantly, it needs to be a universal language and philosophy with no barriers and open to all. And I'll go into more detail about that, but the language has to be a language understood by, in no particular order, obstetricians, midwives, neonatologists, anaesthetists, public healthcare workers, and the government. But most importantly of all, it needs to be understood by the women and their families. And if you have a language is so complicated that they don't understand, there is no interaction. And tomorrow I'll be talking in the oration about how I feel the 10 groups is bringing all kinds of people together, but especially women, which is very much a vision of, as I understand it, of your meeting this year to bring everybody together. Now, again, incidence to me is where everything starts. How often does something happen? Now, to do that, you have to have a definition, and you have to use the right denominators. But if you have car crashes, the first thing you do is count how often they occur. And then you use as a denominator some way to mark that, okay? Now, car crashes may be occurring everywhere, but then you want to know, is it a particular type of car? Is it on a particular road? Is it something else that we can, if you like, make that incidence a little bit more useful? And this is what the 10 groups is about. So it's very important to try and define things when you can. But some things, a cesarean section is very easy to define. It's, you know, the baby is delivered through the abdomen, through an incision, and it's repaired. But take something like spontaneous labor and the diagnosis of spontaneous labor, that's very difficult to define. Everywhere in the world, nobody can agree with it. It's probably the most important decision made in obstetrics, because everything will lead on from that. But we can't agree. Now, when you have a situation when you can't agree, try and bring the information hierarchy one level up. So don't use a classification or design a classification based on variables that we can't agree on. Bring it one level up, and the level up is, fine, you use your definition, but you have to collect the information by, is somebody in labor or is somebody not in labor according to your definition. But once you actually do that, you can design groups and you can get more use out of it. And these other principles of ideal classification are very important to bear in mind, because although we start with the 10 groups, the 10 groups is only the starting point. You need various classifications within that, and I'll come to that as well. But a classification has to be simple. It's got to be easy to implement. It's got to be informative. And I think of it more as an overview as opposed to a very detailed classification. Again, I'll be coming back to that in a moment. It's the starting point. It's what brings people in, and it's not the end point. Ideally, it should be robust, stable. If you have a classification that every year is being changed, it is obviously of limited value. By all means, develop it within the original classification, the hierarchy. Develop it downwards, if you like, but try not to develop it horizontally, because it gets very confusing, often with overlap. Self-validating means if the criteria that you've used occur, or their prevalence in the population is very consistent, for example, like breech presentation, or twins, or multiple pregnancy, you can use those in the classification to actually self-validate it. So you can actually look at data in the 10 groups, and you could actually say, honestly, you can do this. You can say, that's just impossible. Or, occasionally, there are very unique explanations, but some of it is so obviously wrong that you can just say that is not good data quality. It's got to be universal, and that's a very important thing. I talked about the pencil and paper, but the 10 groups has got to be very easily understood and very easily collected at the most basic level. So just a pencil and paper. And indeed, I'll be coming to this again maybe tomorrow, is to show that they have done papers testing women whether they actually understand the 10 groups. And there's a very good correlation with women understanding. Obviously, it may be related to education, but the whole point, the woman could come in and tell you which group she's in herself, because it's very easy to actually understand. And that is the definition of universal, I think. I've talked about prospectivity, so prospective classification, a structure within which you can look at other events and outcomes and then identify which groups they're most common in, is very important. It's got to be clinically relevant, it's got to be identifiable, and it's got to be totally accountable. You shouldn't have a classification which allows some to be missed out, or the other way, as I say below, not to be able to go into more than one group. And you've got to be able to test it, the classification, to see if you give a little bit of teaching to 100 people, will they be able to all classify it? Because it's no good, obviously, if a classification, everybody doesn't either understand it, it's not that simple, and they end up putting in different groups. It still may happen for different reasons, but those errors should be kept to a minimum if the classification is well designed. At the top of the classification, a minimal number of groups is best, I think, not too few, not too many. But at the top of classification, as I said with the hierarchy, they must be ideally objectively defined. Don't do at the top of a classification subjective. That's why indications, for example, which are very subjective and something we struggle with, should be kept well down in the classification and not at the top. So the criteria for the 10 groups are very objective, and that's important. They must be mutually exclusive and totally inclusive. So no one that you're going to allocate to the classification, women and deliveries in our situation with the 10 groups, are mutually exclusive. So they can only go into one group. But importantly, they include everybody. So you can't miss anything out. And when you interpret numbers from the 10 groups, that's a really important part of the 10 groups. You can't, hide anyone outside the classification. And lastly, a lot of classifications in perinatal medicine, certainly labor and delivery, have depended on a definition of dystocia, depended on a definition of this or that. These are variables, as I've said before, that we can't agree on. Remove all the variables out of a classification, look at the classification objectively, and then explain the differing results by then going back and analyzing your processes and protocols and how it compares with another country or another hospital. Exactly what businesses do, exactly what sports teams do, the professional sports teams, and also to a certain extent amateur teams, but the professionals really depend for financial situations to survive. I also want to point out the hierarchy of classification systems. So if you've got a lot of raw data, at one end of the hierarchy of classification systems, you've got no classification at all. You have completely unorganized data and information. You have the data. It doesn't result in any conflict. What I mean by that is disagreement, because there is no classification. But importantly, no useful knowledge is obtained. And I think sometimes our perinatal information, and this is my view, is very typical of that. We've got a lot of raw information sometimes, but no useful knowledge. And that's the important thing. The other end of the spectrum, people have developed, not so much in labor and delivery, but for some examples in that, very specific and organized classification. But it becomes so specific and so subjective the further down the classification you go, it's difficult to get consensus. And if you don't get consensus, not everybody will use it. And therefore, you end up with the same problem. It's not used. No useful data information is available, and no useful knowledge. And that's the kind of idea about the 10 groups. The 10 groups is a balance between those two extremes. It's enough to identify for people, and you need to encourage people to say, well, yes, any more detail, do it within the 10 groups. One of the criticisms, and there have been criticisms of the 10 groups, is it doesn't have this, it doesn't have age, it doesn't have indication, it doesn't have whatever. But it was never designed to do that. You wouldn't be able to do that. You wouldn't be able to get people to understand or even agree. What has happened with the 10 groups, I would argue, maybe I am a bit biased, it has struck a chord with people. It has actually struck a chord. And it struck a chord with those on the front line because they understand it. And because women understand it. And you can talk and use that information. But by all means, within the 10 groups, then record all the detail. And as you get more interested, as you get more into the subject, then that's what's happened. So just very quickly, going through what we use to get and form the 10 groups is these 4 things. So they're the top, they're objective, and they're very clinically relevant, and things that we actually think of all the time but don't realize it. So if we see a woman in the antenatal clinic or in the labor ward, we think, is she nulliparous? Is she multiparous without a cesarean section scar? Or is she multiparous with at least one cesarean section scar? May have had a vaginal delivery as well, may have 2 or 3 previous cesarean sections. But it's very simple, it's very clinically relevant, and it affects whatever decision you make. From a public health point of view, I find it very hard to understand that when I ask this question in an obstetric population, what proportion of your population are actually nullips, multips without a scar, and multips with a previous cesarean section? That's probably the most important information in terms of budgets and other things, because they all have different implications. Nulliparous women take a lot more care. They need a lot more care, and without going into the detail, it's true. If you only have multips, and I preface that by multips with 1, 2, or 3 deliveries. I think once they get to 7, 8, or 9, it's a different situation again. And by using the 10 groups, it's kind of explained a lot of differences between different countries, because you can't sometimes understand why group 3, multips and spontaneous labor, low-risk group, but in many countries, they're very high cesarean section rates, or higher than you would expect. And that's because it's multips. There may be some places in the world that have 7 or 8 vaginal deliveries. And for those of us looking after women in labor, we know that's a huge risk. So again, it's identifying what your makeup of your population. The category of pregnancy is very much influenced by the 10-group thinking. And it's really taking a number of things together: the presentation, the number of babies, and the lie. And it's basically saying that on the labor ward or in the antenatal clinic, you're asking yourself unconsciously, is this single cephalic? Is it single breech? Is it a multiple pregnancy? Or is it single transverse or oblique lie? All clinically relevant, all mutually exclusive and totally inclusive, within which many other things may exist, but the sizes of those groups. Now, single breech and multiple pregnancy are very, very consistent. And if they go outside a certain range of figures, there needs to be an explanation. And I will come back to that. It doesn't mean to say it's wrong or right, but it may question your data collection. And lastly, the course. The course, again, is very interesting. And before the 10 groups, I'd never seen in an obstetric textbook where they've actually put in one paragraph the only 3 pathways that a woman can deliver is going into spontaneous labor, being induced, right or wrong, or have a pre-labor section, which may be emergency or elective. Now, we're not really going as far as saying what the right percentages should be. All I'm saying is, it's never been like that. And on an electronic record, I will challenge you to find that in one particular place. So you've actually got to tick one of those. We seem to have a problem in identifying it, yet it is probably the most important decision where all the other factors come to bear on our decision, whether we allow a woman to wait and go to spontaneous labor, whether we take the decision to induce, or whether we do a pre-labor cesarean section. And by the way, if we induce somebody and they don't go into labor, they're not put down as a pre-labor section because the intention to treat was induction, and they should be recorded within that group. There may be a subgroup of induced labor or failed induction, a term which I find difficult to use and understand. But anyway, the pathway of delivery is very important, and I'll be saying a little bit more about that when I talk about induction tomorrow. And lastly, the gestation. So the philosophy of the 10 groups: simplicity, a clarity of thought, structure. It stimulates interest, hopefully even arguments between. It encourages people to think and to talk, and it does so because they all have an opinion on it. It will result in education and understanding, and it encourages long-term commitment and responsibility, particularly those at the front line of care. It's a very inclusive way of looking at evidence-based medicine. Exclusivity with regression analysis and all those complicated statistics, which I never really understood unless the night before the exam. This is very inclusive. And we're talking about inclusivity, and this conference is talking about inclusivity. That is why it's so important, because everybody will be able to recognize and realize that. And it's based on the premise that all information, epidemiological, maternal, fetal events, outcomes, cost, organization, medical legal cases, complaints, whatever you want to look at, will be more clinically relevant by stratifying them using the 10 groups and their subgroups. Medical legal cases, what if they all occurred in one group rather than another? complaints. You will be highlighting which group, and you won't be having universal changes, blanket changes of management, but focusing where it's needed. And no perinatal event or outcome, including especially cesarean section, should ever be considered in isolation from other events, outcomes, and organizational issues. And when you have good classification and standardization of data in any objective way, any differences in sizes of groups or events and outcomes within the groups, I would challenge you to say that due to only one of three things. And at the top, poor data quality, either in collection, in definitions, or something to do with the ability to get the data. Secondly, differences in significant epidemiological factors that may affect the sizes of the groups or the outcomes. But then only lastly, differences in practice. But they're three very different things. I get to be asked to review a lot of papers on labor and delivery, and I'm fascinated by this issue about poor data quality. I start from the point that journals, or the big journals, really only want randomized controlled trials. I'll say it as bluntly as that. I mean, they are getting better at good quality observational data, but a lot of observational data isn't good quality. But interestingly, when you write a paper on an observational trial, and you know, which should be registered and the methodology registered beforehand so you can show an impact and you declare what you are trying to do, but observational data has really sometimes always been just writing a list of all the outcomes, but no solution, because you can't identify which groups to change practice in. And this is where the 10 groups changes things. But I'm really fascinated where there's this philosophy or a culture in the people that write the paper. If the information isn't good, they don't include it. I think we should include where we've got poor data quality, but comment and say that you know it's very poor and you want to improve it. If you just ignore it and write a paper like cesarean sections, and you've had a fall in cesarean section rate, but you haven't included the indications or no attempt to actually look at the indications, there's something really big missing. It's not good enough to say, well, it doesn't really matter, the section rate came down and the outcomes were exactly the same. So I think we should look at include not only good data, but also data which we are, you know, maybe a little bit suspicious of. Now, that's not, everybody would agree with that, but I think unless we take this issue of data quality one step up and we admit, we look ourselves in the mirror and say we're not very good at collecting data, then it won't change at all. The validation of the data quality and clinical interpretation is possible because of the relative homogeneous nature of the 10 groups, and also because of the consistency of many of the events, outcomes, and complications within these groups. It's quite remarkable how consistent and how much you can tell. And hopefully we'll be showing local data later on, and I'll be looking at it and showing how I can interpret, how I can question, and not about the practice as such, but, you know, highlight what you can learn. So, just finishing this section off, we're saying, let's turn everything around. Rather than telling everybody this is the way to do things, why don't we embrace different ways of care and respect and acknowledge different ways of care, either in different countries or in different units? Let's bring everybody together. And rather than concentrate on this, what we have been doing, standardizing processes, because we haven't succeeded, standardize the way we carry out perinatal audit so greater learning and comparison can take place between delivery units. Develop this common language. And I think that will result in a more gradual coming together in the way that we practice, with some differences, because I don't think we can all practice in the same way for all kinds of reasons, resource, culture, religion, a lot of different reasons, but we'll learn from each other. And as the final slide of this section, the actual detailed processes of care are not what I believe will define us as midwives, obstetricians, neonatologists, all the others, but the standardization of information collection on events and outcomes surrounding labor and delivery will. And sometimes I get asked to review labor wards, hospitals. I ask to look at the labor ward register. I ask to look at their information. And you can tell a lot by looking at that. You ask to look at the clinical notes, and you will tell a lot from that. So that's the end of the first session, and I believe we've got about 20 minutes for discussion, but we may have started a little bit late. So I was going to see and open the floor up. I hope there's some questions. There's always a moment at this stage where people hesitate to ask or be the first one or whatever. Please, come with any criticisms or challenges or seeking explanations. I mean, the most important thing is that I respect if you don't agree with what I say. I respect that, but please do understand what I'm saying. That's what I'm saying.
Thank you very much for your explanation and everything. So my question is, now we consider the cesarean scars only. Is it only the cesarean scars you mentioned there, CS scars?
Yeah. It's a very common question, a very important question. I think for a classification, it's got to be objective, okay? So I think that if you included, and presumably you mean a myomectomy scar or something like that, the advantage of having a cesarean section scar is very well defined, okay? If you have a myomectomy scar, if you have a perforated scar or whatever, it should be still within the group, i.e. nullips, but within the classification for indications for cesarean, you would put that down within that group. Yes. I think that's the only way round it. And it comes back to one of the principles. It's got to be replicable. And if you have things like that, it won't help to telling you what the sizes of the groups are in terms of clinical practice. Cesarean section, and I'll come to that a little bit later on, is a very key part of our practice. The debate is a complex debate, and it's gone into one direction by a group of people and then into another direction by another group of people. But precise answer to your question, it's more because of information collection is standard with a cesarean. It would be, and the sizes of those previous scars, if you include it as a group, would be meaningless. Yeah. Please, anybody else?
I also used this 10 groups classification system in my first year to do an audit at teaching hospital Anuradhapura. Since then up to now, I have one question remains in my mind. So for the induction and the cesarean section, the pre-labor cesarean section, as you said, the obstetrician's objective for the induction is to aim for a vaginal birth.
A safe vaginal birth.
Safe, yeah. So what, and the cesarean section, pre-labor cesarean section, the objective is obviously going for cesarean, it's pre-labor cesarean section. So what lead you to put these two together in the group 2 and the group 4?
Why did I separate them out?
Yeah. Because the...
why did I include them as separate groups?
No, why you could, why you input...
why they were given a separate group?
Yeah.
Because if you have, and you will know that in single cephalic nullips and in single cephalic multips, they have separate groups. Group 5 is a more heterogeneous group. But it's a very clinically important differentiation. So if you take the cohort of group 1 and 2 together, it's a very important clinical concept to know what proportion of those do you intervene with. Do you end the pregnancy artificially for whatever reason? So that's why it's in a different group. And the sizes of that will depend on stillbirth rates. It's related to a lot of other things. So you can look at the ratio between group 1 and 2 and decide. To analyze data, you sometimes, and I think if that's what you're driving to, I agree with you, you sometimes have got to amalgamate the groups as well to look at the overall rates within that cohort, but also you've got to separate it out. It's interesting you asked that question, because one of the more common 10 groups challenges or critiques would be, why haven't you added another group for 2A and 2B as a separate group? And not so much your question is why did you separate 1 and 2 into 2 groups, which, if I understand your question, that's what...
Why you couldn't separate 2 into 2 groups, like induction?
Why don't I do that?
Yeah.
Because what one obstetrician may induce, another one may deliver by pre-labor cesarean. The key information, the useful knowledge on the immediacy of looking at the 10-group table is what proportion did you take out and artificially end the pregnancy. It becomes more detailed about what you induce and what's pre-labor cesarean section, and you have to, have those subgroups, and you have to analyze further by indication and other things too. But if you put on a slide, more is less and less is more sometimes in converting information. So when we look at that information later on, if you had 12 groups or 14 groups, there's only so much that you and I can look at and get information from straight away. Otherwise, you'll have to be adding groups up. But the important clinical, I don't know, maybe people don't agree, but the most important clinical thing to me is not necessarily at the first stage what proportion was induction and pre-labor section. That is obviously important and it comes afterwards, but what proportion of 1 and 2 did you take out and with the intention to deliver before they went into spontaneous labor? Did I answer your question?
Yes.
Yeah.
Yes, thank you.
Mr. Robson, thank you. Just want to ask, do you have any audit standard, like things say that a nullipara has to have, nullipara who has gone into spontaneous labor should have this amount of cesarean section rate? Because for each group, do you have any kind of standard, or you are just...
Yeah, now we really get into that. And in the WHO, as I'm sure you're aware, they were kind of trying to say that. But I don't think you can really say there's one benchmark or one standard from the point of view of interpreting whether it's good or inappropriate or appropriate care. But I did agree that we would put a range with, if it's outside that range, you should think about it and have an explanation. The longer I've been with this, I've understood that there are other reasons that nobody has ever brought up before that may explain this. But remember what I said, because this all started from group 1 and fundamentally about the argument of dystocia and the management. That's what it's come down to. The diagnosis of labor, dystocia, and the problem with dystocia, either spontaneous labor, particularly because usually it's a larger proportion, but also induction, and its implications for maternity care afterwards. That's what obstetrics is about. We can talk about preeclampsia, we can talk about all of the other things, but it's basically about the diagnosis of labor and dystocia. So I devised group 1, and we need to look at it, but and remember, this was in 1988. At that time, that debate was going on. So I thought to myself, why don't we just look at that as a group? The problem I soon realized is people sometimes don't put people into spontaneous or induced or pre-labor section. To identify and really study group 1, what you need to know? You need to know what's being left out in group 2. Because if you only include 5% of the population in group 1 and you've taken out all the difficult ones out there, you will have group 1 with an section rate of 1%, an oxytocin rate of 2%, no vaginal operative deliveries, do you understand what I mean? So you have to actually understand what's in group 2. But in answer to your question, you need to know the sizes of the groups. You need to know the 10 groups first of all. Don't ever look at one group or beware if they can't produce the other 9 groups. The other 9 groups will give you an idea of what kind of hospital, what kind of population, the even numbers, how big were the numbers. They will tell you what they've left out, how many they've been left out. They'll tell you whether they're able to classify all of the women. And if you don't get a good idea that, yeah, this looks reasonable data, say you can't comment on group 1. If the size of group 1 and 2 are so low, it may be something to do with the population. There are a lot of populations in the world where group 1 and 2 are getting smaller and smaller. European countries in particular, and some countries like Italy, the nulliparous woman is getting less, higher and higher. They're only having 1 baby. Sorry, I meant it the other way around. They're much less having 2 babies. The 10 groups will tell you a lot about those things. But to study one group and study group 1, which you and me maybe are very interested in, that's the reason behind all of this, is there are a lot of other things that you need to know within that group apart from just the section rate, you know, the baby outcome, the oxytocin rate, and sections at fully and whatever. And I believe, I mean, later on in the workshop, I'll be showing you the relationship between those factors, which is kind of very exciting, I think, but I'm more of a purist about spontaneous labor.
Thank you.
Sorry, I'll give you.
It's okay. Dr. Michael.
Yeah.
So, first one question.
Yeah.
I work in a very high-end referral center, where Colombo Diocese Hospital, where most of the referrals come, and we have very high-risk patient base. So I actually developed your classification into a more of a AI-based app as well. Yeah. And we have done many research on that, and it's working. But what I got, the problem when I implemented it in our ward was actually our cesarean sections in group 1 and 2 are increasing. I mean, it's very high. Yeah. So the indications for these things had to be also put in there, because otherwise it looked very not very nice.
You can't explain it, yeah.
Yeah, you could explain why it goes so high. So the other consultants were not very happy that, because our population is totally different. So question number 1 is actually, why didn't you include that in this classification? Maybe the universal marks.
I'm very happy to answer that. It wasn't included for the reasons I gave, because you can't include everything at the first level. But in about an hour and a half time, I'll give you everything you want to know about indications.
And the second thing is what Madam was asking, whether you have a universal. I personally believe there cannot be a universal rate at all, because each and every unit is having their own difficulty. So it's actually a classification where you have to devise your rate. And
I totally agree. But where I would agree with Madam is that you have to have something to know whether it's high or low. Car crashes, you know, you have to know something, you know, where you can start and say, we need to look at that, or that rate is very low compared to everyone else, you know, etc. So you need to do something. Have you published any of your data?
Yes, so we have validated the app. That is published. The other things that we are writing, we did a
the results. Have you got your 10 groups with you, or can you? It'd be great if you can show it to us later on. I'll be really interested in looking at that. Yeah. No, I think I'm going to talk about caesarean section, and the optimal caesarean section is not a number. It's not something that stays still. It's not something that's same, but it's what you as individual organizations know about your caesarean section rate, why you do them. That's the optimal caesarean. And that's a philosophy rather than an exact number. This number business is, you know, I mean, the WHO said 10 to 15% caesarean section.
It's the multi-country survey and all these things, I mean, they have given, but that will not correlate with most of the units.
No, but hang on. There's an actual, well, not so much an explanation, but it's gone over the head of a lot of people. They have said that 10 to 15% won't affect the neonatal mortality rate. Do you agree? Yeah. Yes. The neonatal presumes that the baby is born alive. It was never intended to look at preventing stillbirths. Do you see? Yeah. So everybody is confused or equated synonymously perinatal mortality rate and neonatal mortality rate. To prevent a stillbirth, what have you got to do? Sorry?
Just to deliver.
Deliver, either by the person that is talking, before about the induction. That's why that number is so important. So if you see 1 to 2 with a very high ratio, i.e. the size of group 1 is about 7 or 10 to 1 ratio, the first question I'll ask, what's the stillbirth rate in that population? Does that make sense? Because, you know, they all fit together. Anyway, thank you. Any other questions at the back? Yeah, no, do they want to have you heard of it? Do you understand? Or is it very confusing? Or are you worried I'm coming down here? Or you were sitting very peacefully here a minute ago. Because it's interesting. I lecture to medical students and I lecture to, people in training. We're all in training, really, just at different stages. And it's like everything in life, you know, when you're young, there's certain advantages. When you're old, maybe there's certain disadvantages and things change. So it's really important. This is an ever-developing thing, so it's very important that those of you who are going to be consultants in the future understand, buy in, and contribute to it. Do you understand the basic principles? I'm looking at people, I don't know what level as you are, but you understand the principle of it. Yeah. And the other thing that I keep on saying, there's no country yet that has taken this to the point where they can claim the prize. And a lot of it comes down to, yes, the philosophy, but more importantly, the actual availability of information quickly and in a structured way, which we'll be talking on later on. Yeah.
Well, my question is not really what I think most of the obstetricians are wanting to find out, and I think you have nicely brought it to a level of understanding that it's all about analyzing the data. And yeah, but you mentioned interestingly that the classification is useful to the women who are actually undergoing the process, right? In a very educated society, I believe. How is this, how do you make use of your classification?
How would I, or how do we?
For the women.
How do we?
Yeah.
I mean, there are a lot of things, you know. So, for example, we have antenatal classes where we have antenatal classes according to whether it's a first baby or second baby, whether it's a previous section or otherwise. So we try and educate is such a word that is used in such a way. It can be kind of misconstrued. I don't like talking about educating people. I think it's too, but discussing and explaining. So women will, come out with questions which I think are really useful. I'm in group 1. What's the likelihood of me having such and such a length of labor? What's the likelihood where I am going to deliver? Not in the latest randomized controlled trial, which actually doesn't give absolute outcomes from the UK or otherwise, but in my situation and coming into this hospital, my local hospital, what are the chances? We do know that familiarity or understanding that something wouldn't be as unusual as sometimes women who come in to deliver and they get very worried about it, I think is useful. So you could go on and on. Now where you cut the information and where you get challenged and say, well, you're just scaring people by telling them that you've got a chance of this kind of chance of a cesarean, this kind of chance of a vaginal opera delivery, or this kind of chance of any other outcomes. How much you tell people has to be, to a certain extent, up to the clinician, I think, in an individual situation, and how much individual women want to know. But I do feel we should know certain things ourselves. So I was trained, or maybe I got interested, I would know things like the average length of labor in a first-time mother, according to whether she comes in at 1 centimeter in labor, 2 centimeter, 5 centimeter. The oxytocin rates will vary, the length of labor will vary, the likelihood of a vaginal opera delivery will vary. I encourage midwives to kind of think to themselves, what's the likelihood of this woman delivering vaginally? And indeed, is she a woman that will need an episiotomy? Or, that kind of information. So bringing it down to that level. How much information you give somebody, as you know. When we consent somebody for a cesarean section, I'm sure some of us feel at some stage, I could give all the possible complications and she might refuse to have a cesarean, while I know that she needs one. So it's a very responsible job to know what information you can give, but certainly women are beginning to know. There's a paper published from Portugal where they took a group of women and they taught them and explained about it, and they understood it, and they put themselves into the different groups. But you need to have the additional information within those groups to make it useful.
Now, we have an issue in Sri Lanka. Now we have very high induction rates, as well as cesarean section rates. I think as clinicians, we may be doing, but I think is it a worrying issue for the country now? Yesterday we talked about health economics, about cesareans and the deliveries. If it is normal delivery, vaginal delivery, it may be lesser, but you told the other way it may be equal. Yes.
I like creating discussion and debate.
Yes.
Everybody says, I got trained by an obstetrician, and the first, in Dublin, I have met a lot of good clinicians. By the way, I actually did fellowship in general surgery as well. I wanted to be a gynae oncologist. That was my first aim, but I went to Dublin and I got involved with labour and delivery. But the reason I'm telling you this story is that I was very fortunate across my education to come across teachers that said things that stuck in my mind. And one of the teachers in obstetrics, started asking me questions on the first day I came to the National Maternity Hospital. And I didn't know the answer. And he turned around in this way and he said, "Do you think you should know?" I think it was the incidence of preterm delivery, and that stuck in my mind. And the other kind of question he challenged me was, he said, somebody's got to swim against the tide. And what that means is we do need checkers all the time, to kind of check things. And, as a group here, there may be some people that do exactly what they're told and the guideline and don't think about it and whatever. There are other people that don't do anything, the other extreme. And then in between, there's people that just, you need a bit of both in an organization environment. You need somebody. So I asked you a question about induction, and I'll be talking about it tomorrow. The title, for those of you who haven't seen it, is Induction of Labor. Is there consensus, and does it really matter? It's going to be an interesting lecture, but it's looking at things in a different way. I think anything you don't know about that is increasing, car crashes, you need to know about. You need to know to audit it in a standard way. You need to know whether it's going up or down. You need to look at it as an individual process and event, and you need to look at it in terms of, as we talked, removing the women from group 1 to group 2 and what the effect of that. Have any of you heard of the Will Rogers phenomena? The Will Rogers was a comedian in Oklahoma, and he was the guy that they gave this statement to, or they put it down to him, is that if one part of, I can't remember, there's two types of, there's a divide in Oklahoma, but if one group moved to the other group, the intelligence level will go down or increase in both populations. It's a very important statistical concept. So if you moved a lot of people from group 1 above the average of group 1 in terms of cesarean section rate to a group 2A, which is lower than the average, you will increase the section rate, decrease the section rate in both 1 and 2A, but overall you'll increase the section rate. Does that make sense? Or you can sometimes decrease it, but it doesn't affect it overall. So there's the joke that, if Swedes went to Norway, it would increase the intelligence level in both places. It doesn't work like that, but it's below the average. So you have to kind of work out what the effect of induction is. And remember, what are we doing on this for? Safety and quality. But it does, show you. I think the induction debate is a very interesting debate.
Inductions also to prevent stillbirth most of the time.
Sorry?
It's like inductions are also targeting to prevent stillbirth.
Yes, there they are, yes. And that's the only logical reason. But some of the literature that's come out at the moment says that it actually reduces the section rate. I don't think it's that simple as that. But protagonists are either on one side or the other. I mean, as I'll say tomorrow, it may not affect it. It may increase it. It may decrease it. But you have to know your spontaneous and induced and pre-labor section. So if you've got a large pre-labor section group and you move it into inductions, you're going to reduce it. But if you move more spontaneous labor into inductions, and that way, it'll increase it. So it depends what your outcomes are. I don't know how we're doing for time, but we better move on to the next question. But at least, anybody else got a question before we go on? No, okay. So we'll go on with the... Now, presentation and interpretation of the data. There are some standard papers that is probably worth, or some key papers, if you like, about the 10 groups. The first one was one of them is an editorial, apart from the original description. The 10-group classification, a new way of thinking, that was an editorial in the American Journal. And then there is a commentary in the mini commentary, very easy to read, very quick, in the BJOG, which was entitled Known Knowns, Unknown Unknowns, and Everything in Between, the 10-group classification system. And it was an attempt to explain that by using the 10 groups, you will discover things that you never knew before. And it was also emphasizing that caesarean sections were not just a classification of caesarean sections, that it's become popularized by that, but it's a perinatal classification system, a prospective one at that. It's simple, it's objective, it's a common starting point, nothing more, nothing less. And we need to introduce or be aware of this intention to treat concept, which I'll go into more detail later on. Totally inclusive, mutually exclusive, and informative. But it is merely a beginning, not an end in itself. And the gentleman over there will understand, hopefully, that, you know, if you put everything in, and people think that you'll put everything in, that's the problem. It will be too complicated and nobody will use it, or nobody will bother to even read it, as busy as we are today. But one of the principles is that you have to have a standard presentation table and slide. And it's remarkable to me, and it explains certainly why we're not able to standardize a way of looking after women, because it's so, we can't agree on that. We can't agree on a standard way of classification, and it's simplified even more that we can't even agree on a table to present the 10 groups. Everybody has their own version of the 10 groups. And so many papers, understandably, maybe get sent to me, and everybody has to rediscover their own way of making a simple table and 10 groups. And I'm raising that as a point because when you show the 10 groups, surely it would be better if we had exactly the same table, exactly the same size, simplicity, more is less, less is more, but we don't have to spend the first 5 minutes trying to work out what we may be used to from our own table. And the WHO in their manual suggests one table, but the original description, and one of the original descriptions in its use of caesarean section showed a very much simpler table. So we ended up with 10 groups, and there's a story behind that. You know, why 10 groups? Why not 12? Why not 15? It was basically a balance between homogeneous groups, but not too many groups. And 10 seemed, in the decimal age, a very suitable number. It fits nicely on the slide. And in red there, at the bottom, you can see unclassified. That isn't a separate group, but if people are unable to classify, it's a very important quality marker that should be there. I won't go through the individual groups, but just try and explain some of the thinking behind it. The actual order of the groups were thought of very carefully and have very deliberately been chosen. Group 1 is group 1 because that's the start of everything. First baby, spontaneous labor, that's a majority of women. And it's actually why the 10 groups started. So it deserves that place. As I've said before, you can't understand or study group 1 unless you know what's in group 2. The problem is with data collection as it is, group 2 may not include all the real group 1s and 2s. They may be somewhere else in some of the other groups. And that's why you need the rest of the groups. it seemed logical after group 1 and 2, single cephalic nullips greater or equal to 37 weeks, to have group 3 and 4, which are the opposite, if you like. They're multips, basically spontaneous labor group 3, and multips, again, induction or cesarean before labor, but importantly, they've got no scars, cesarean section scars. They may include the other scars, as we as discussed, and that will come out with the more subjective information within the groups when you analyze either cesarean section rates or any other outcomes. So that took up most of the term single cephalic pregnancies, but there was a group 5, which is single cephalic, previous cesarean section. How many groups do you make of that? Now, this is a smaller group, and the real main information point of view, to bring up your point, was there less is more is less, to bring over, is the number of women with one previous scar, at least, with vaginal delivery that get to term. And it's obviously a very heterogeneous group, and it has to be split up, maybe into one cesarean and 2 or more cesareans, first of all, and then spontaneous induced and pre-labor section. And you will do that, as we do in our clinical report. But it's the size of that group when compared to the sizes of the other groups within the 10 groups as they exist at the moment, that will give you immediate information of where that organization has been, and indeed where that organization is going to go with their cesarean section rates. And classically, some relationships come up, and in the well-balanced standard population, I'm not saying it's everybody's population, but the size of group 5 is often half the total cesarean section rate. And it's trying to emphasize that the previous scar stands out in its contribution wherever you are in the world. Group 6 and 7 are the breaches. And then you get this fundamental question: is preterm delivery the key clinical component in the 10 groups, or is it the breach itself? For different reasons, and we can go through it in the discussion, I decided it was the breach. But it wasn't only that it was the breach. Nullip breaches are very different to multip breaches. And they're very different in many different ways. And you remember, this is a classification for the whole world. Not everybody would section breaches straight away. It's happening in some countries, and you could argue, and we can have a whole session on that. But interestingly, the incidence of breaches is much higher in nulliparous women than multiparous women. Did everybody know that? Please tell me you didn't know it, because I didn't know it before. Breaches are higher incidence in nulliparous women. So not only is there different, you'd have a different approach to labor and management in a lot of countries, maybe not here, but also you'd have a difference in size of those groups. And that becomes a very valid data quality marker, which I'll come to, and hopefully it will show up in your own population. And breaches also will depend on more than parity. It will depend on preterm. So the size of group 10, the bottom group, is only preterm single cephalic pregnancies, but it serves as a proxy. Otherwise, the other way of doing it would be to include twins and breaches, all the preterm, all in one group. But it won't give you as much information as that first table. And as I've said, you've got to sometimes combine some of the groups to get all preterm deliveries. So 6 and 7 was relatively easy, and the ratio of breaches is usually about 2 to 1.2, something like that, nullips to multips. The multiple pregnancies is interesting. It's a women-based classification, so you're not counting babies, you're counting women. But there's been countries where they've had a very high size of multiple pregnancies in group 8, and they've been counting babies and not mothers. That may sound strange, but how did they have any way of checking it? They never checked it, either because of the denominator they used, or for other reasons that they weren't looking at it all the time. And we know that multiple pregnancies, the standard thing would be, with no IVF and no referrals, would be maybe 1.7, 1.8%. There will be certain ethnic differences, but the biggest reasons it vary is IVF and referrals to tertiary referral centers. So that will explain something about high-risk units. Group 9, why do you have a separate group 9? Why don't you just throw it in with the breaches? The interesting thing about group 9 is the consistency of it. It is always between 0.3 to 0.8%. And it always has a 100% section rate, because it's only a transverse lie if it is sectioned. If you have a very preterm delivery, a 25-weeker, 26-weeker, really it gets sectioned for a transverse lie because it squeezes one way or the other into head or into breech. But whether you look at 200,000 deliveries classified by the 10 groups in Peru, whether you look at Ireland, whether you look at anywhere, it is so consistent, that group 9, that it becomes a data validator. And we'll see from your own data, and I'll be very surprised if it shows anything different. And in fact, one of the Scandinavian countries, up till about 15 years ago, the Scandinavians have always been interested in the 10 groups, had a 3% incidence of group 9. I mean, that's just not, doesn't happen. And they actually showed that their breaches were a lot lower. So there is a little bit of subjectivity in defining that, but it is useful. The single cephalic preterm, because of the larger preterm contribution in general, is a very good proxy for preterm delivery. And obviously, if group 10 is big, then the number of breaches will be higher as well. Why no subgroups? I've emphasized this again. Less is sometimes more in communicating information. But the specific rows and the way you look at it is very carefully designed. So the first 5 groups are the biggest groups, with not necessarily low cesarean section rates, but certainly lower than the last 5 groups, which are much smaller, but have much higher cesarean section rates. So the way that we look at it, using cesarean sections, but you can look at many things within the 10 groups, you count up the raw numbers, and you can see our section rate, 34%, has gone up like many other countries. And yeah, like many other places, we say we're a tertiary referral unit, and that's the reason. But it isn't always like that, as I'll show you. So the number of sections in each group adds up to the total, and the number of deliveries in each group adds up to the total. And the first thing you do is look at the sizes of the group. And if you're studying or use the 10 groups, never, ever, ever look at the section rate before you've looked at the sizes. And make sure you validate the sizes to what either is consistent in your own groups, or indeed, makes sense clinically. And you can see here our ratio. We were talking about induction. About 10 years ago, that ratio between group 1 and 2 was about 3 to 1. Now it's 1 to 2, nearly 1 to 1.8 or 9. And this is because of this evidence-based medicine about inductions, and therefore we should be inducing. And this inevitably, unless you've got an organization which really is so disciplined that nobody can do anything without passing it through senior people, one senior person, then people will end up, using not standardized care, unstandardized care, but certainly making individual decisions. And I'm not necessarily saying that's good or bad. I'm just saying that this is what's happened without any policy, if you like, from the hospital or the master saying that we should do that. That ratio between 1 and 2 is always less than the ratio between 3 and 4, the sizes. What I'm saying there is we intervene far more often in nullips, although they're more difficult to intervene and induce, than multips without a scar. And that is a consistent data validation. If you ever see a 10 group, send me them. If you show that whatever the ratios are in 1 and 2, if the ratio is less in 3 and 4, that's very, very unusual. It could exist like anything else, but it's a validation thing as well. So you can see here our size of group 5 is 14%. It's a little bit less than half of 34%. Our size of group 6 and 7, you can see, is 2.6 to 1.3 breaches. And remember, the sizes of group 1 and 2 is about 36%. So at the moment, we've got about a 41% nulliparous population, but more breaches are in nullips than they are in multips. in terms of absolute numbers. You can see our size of group 9, 0.4% and 100% section rate. I'll show you in a minute. And our size of group 10 is 4.9%. Now, these are figures that are published in the WHO, and they're not figures to suggest this is good or bad practice. They are figures to suggest if you're way outside those, you need to just find a reason, or that's how I would use them to advise that. Then we look at the cesarean section rates within the group. Our section rate in group 1 has gone up a lot. Our section rate in group 3 has remained absolutely static. And if you remember these figures to later on when we look at your own, it will be interesting for comparison. But the section rate in spontaneous labour in our hospital would be considered low, although I feel it's gone up a lot in group 1, which is the group that started all this off. But you see all the section rates here in groups 1 to 4, they're lower than all the ones in 5 to 10. And 5 to 10, apart from group 5, all of these groups are relatively small groups. So when you look at the numerator of the section rates, so the number of sections, you take that over the total denominator, you will be able to work out the contribution that each group makes to the overall cesarean section rate. Now, when you do that, the actual contribution will depend upon the size of the group, because the bigger the group is in size, whatever the section rate is, it will contribute more to the overall contribution to the overall cesarean section rate. But it also obviously depends on the cesarean section rate. So you can see here that the 3 biggest groups in our population, very few are spontaneous labour, because that's one of the things about active management of labour and the section rate in spontaneous dilates. But the 3 groups in most populations are 1, 2 and 5, and they're the big contributors to the overall section rate. And the important thing to understand is 6, 7, 8, 9 and 10, a little bit of an exception, because that's slightly higher. These groups are so small that even if you sectioned all of them, and most people nowadays, I'd be interested to look at your figures, do, the actual contribution not only can only go up to a certain level, but it's a very small proportion of the overall contribution. The issue about cesarean section is groups 1 and 2. That's the important thing to understand. Now, having used the 10 groups more in all over the world, 3 and 4 does seem to be an issue in many places as well. And that may be because some people are having the 7th and 8th vaginal delivery. Even though they haven't got a section, they're high risk. So that's what certain countries have to look into more detail and find out what the reasons are. And I'll be coming back to indications later on. And I'm glad you asked that question, actually, because it is a mess, indications for cesareans. Anyway, as I've said before, the validation of the data quality is possible because of the relative homogeneous nature of the groups. But there are sometimes some unique data sets, and the 10 groups will lead to asking the questions rather than provide the absolute answers. Okay. So we'll continue while the going is good. How are you all doing? What time are we stopping, or what was the plan? I can't remember. Have you got the program there? After this. So I think I've got one more to talk about, and this is the cesarean section debate. Is that right? And then we'll stop. Well, this is going to be interesting, okay? It's a relatively long one. I mean, are people dying for a little bit of a stretch now? And we could do that. We've been going for, what, an hour and a half. Now? I think, though, because this is really interesting, really important, and it's a big section. Not big, but bigger maybe than the others. So we'll stop there. But are there any questions before we stop for a tea break? No, we didn't have any. No, it's a very good question. Everybody has problems with the data collection. But the 10 groups will show you straight away, if you can't classify it, or if you have an electronic thing and it isn't classified, you've got to check it. You know. the two kinds of data, people that know they've got errors and people that think they've got no errors. There's nobody that hasn't any errors. That's why I was saying early on that we should be writing about how poor our data collection is a little bit more than just cherry picking what information we've got and writing about that. But yeah, we often have things each month, and we go and check it and try and find out. And usually it is like electronic. You think, you know, it'd be very easy, but people can, you know, tick the wrong thing, or the wrong history is taken, or something like that. Anything? Any questions? Or are you thirsty? Yeah, okay, so we'll have a tea break. How long do we, when do we come back? So 20 minutes, or how long was the tea break originally? 20 minutes, okay. We'll say 20 minutes and we'll be back. I'm not sure where tea is actually, but anyway. Thank you.